Much, and thanks Atul as well as Marina for their talks, and Josh as well. The radioactive question, David, which you didn't ask, is how do you define the elderly, which we don't want to address that. I want to speak very quickly, very succinctly to the topic of medical comorbidity, but there's really just one word, it's metastasis, how obesity metastasizes to the brain. When I first started as a psychiatrist, I asked myself, how come my patients are so overweight? And how often these patients have eating disorders, diabetes, metabolic problems, and all these problems. I started to think, how can I understand this? It turns out we've learned that there's a brain region that subserves much of the disturbance that leads to this type of behavior. So I talked about trauma as an attenuation of treatment response. If you want to, in fact, augment treatment response, of course, get good sleep. We also want patients activated through exercise, cut back on the alcohol, avoid recreational marijuana. And there's lots of evidence now to show that by losing weight and improving metabolism, there is, in fact, a beneficial effect on treatment response. I'm also going to speak very briefly to the topic of overlapping substrates, that is, the brain substrates that subserve obesity and eating disorder, as well as something I've been interested in a long time, that being migraine. Now, I'm not here to say that, to enlighten anyone, to say that our patients are differentially affected by multimorbidity. We know that's the case. The real question for me is, what's the underlying lesion that leads to this? And it starts off with a very well-known comorbidity, ADHD. ADHD not treated leads to overweight, obesity, depression, and substance and alcohol misuse. ADHD can be actually really boiled down into a brain disturbance cutting across many domains, of which disturbances in cognitive control and disturbances in reward-based activity are well-known, highly replicated brain lesions. When I first started as a resident, one of my very first studies I ever did was looking at migraine in patients with depression and bipolar. And it's so interesting because antidepressants, mood stabilizers are used to treat migraine prophylactically, in some cases acutely, but largely prophylactically. And what's so interesting about migraine, like ADHD, it also shares many common units of analysis, not just at the molecular level, but at the cellular level and at the circuit level. And you all know the more headache you have, the more depression and anxiety you also see. So when you see people with depression, you're seeing people who have a relatively finite number of domain disturbances. 2/3 to 3/4 of all of the functional impairment in depression can be distilled down into two domains: the disturbance in cognition and reward. What's the third one? Largely what Atul was speaking to, that being chronobiological disturbances. So when we get into the molecular aspects of this, it's so interesting. Patients come to us, we hear fatigue. David, how often do you see patients who are fatigued, tired, apathetic, brain fog? What they're saying is, I've got decreased dopamine expression in my striatum. And on the check-in sheet, they have ADHD, overweight, obesity, depression, they can't sleep. And so there's tremendous convergence at multiple levels in these conditions. I want you to look at the red rectangles. What am I saying? Your depressed patients who are overweight and obese are more likely to report anhedonia, more likely to report fatigue. Why fatigue? Are they missing ATP? Are they missing mitochondria? No, they got lots of those. The reason is because they actually have an impairment in reward. That is the effort expenditure worth the anticipated reward? The answer is no. It's so interesting because the drugs that we frequently prescribe to help patients with overweight, obese, have already been shown to be effective in treating a variety of substance use disorders. Here's an article in the New England Journal of Medicine showing that Contrave is highly effective in treating methamphetamine use disorder. That's an incredible proof of concept that obesity in many cases maps on to a brain that's actually subserving addictive behavior. More recently, we've taken an interest in repurposing. You've heard about ketamine. You've heard about repurposing drugs for insomnia. We've had this behavior going on forever in migraine, and there's studies underway right now looking at very new drugs that are approved for migraine, these sort of calcitonin gene drugs that we are now looking at as potential treatments for depression. So when we look at this clinically, we cascade down into the underlying substrates, we think academically what's going on here It's not just some process. What we're trying to do is we're trying to find points of convergence that could actually lead to repurposing opportunities for medications for patients that we see. You cannot have a conversation about managing depression without having a conversation about below the neck, specifically overweight and obesity. And you can see here the treatments that we have approved in Canada. What we frequently use is liraglutide, semaglutide, more recently other incretins I'm going to talk to in just a moment, as well as Contrave. And these drugs can be added to pre-existing antidepressants. Rodrigo Manser in our group, he has done some wonderful work with incretins. These are drugs for weight loss and diabetes. He's shown that these drugs actually improve your hedonic tone, make you smarter, you perform better on cognitive tests. So when David sends me patients from his clinic, he's just a block from the Toronto Western Hospital, it won't be uncommon for me to suggest a incretin, of course, wildly off-label, in fact, to treat symptoms like fatigue, apathy, cognitive inflexibility. And there's some really cool data in the world of type 2 diabetes and obesity showing that incretins, in this case dulaglutide, has brain protective properties in diabetics. And diabetes is a condition not only associated with depression, but profound cognitive problems, so-called diabetic encephalopathy. So when I hear this story that incretins can help reward and help cognition, I think to myself, aha, this might be something that we can use in the patients we have depression. Finally, I talked about this a moment ago, the drugs that we use. I want to really press this point that these drugs can be added to your existing antidepressants or mood stabilizers in patients with mental illness. Increasingly now, Contrave and the incretins are the drugs that we go with. Yes, they lose weight, they correct metabolic systems, but they are also well known to have target engagement in key brain regions that we are also trying to target with our medications. 25% of people with bipolar, 15% of people with depression have binge eating disorder, and we prescribe psychostimulants, Vyvanse preferably, but we move on to other amphetamines, and in some cases we will use non-amphetamines. Sometimes, of course, we'll use SSRIs, but our drugs of choice in this context are, in fact, to use drugs that target the catecholamine system primarily in these conditions. One of the questions that, in fact, has come up frequently for me over the years is how long do you stay on these medications for? Similar to depression, we stay on these medications as needed with periodic reevaluations. We wanted to finish with that because this question's come up so many times about managing this in real-world patients. And David, lots of questions have come in around CRTC and how you can refer to the CRTCE. We have locations in Ontario and in Montreal, Ottawa, 2 in Toronto, 1 in Montreal. You can go to the website at crtc.com and make a referral therein. I want to pass the floor over to David if you've got a couple of remarks, and then I'll finish off with a couple of final remarks.
Unfortunately, I wanted to say that that patient you described, I pretty much see him every time I look in the mirror these days. So it's anyway, I think I can speak on behalf of everybody tonight to just say that this has been an absolutely amazing night. There's been loads and loads of wonderful information from some really smart, committed, dedicated, lovely people. So I want to thank the sponsors. Braxia, I'm happy, thrilled to be part of that group now. And I hope that we'll have lots and lots of opportunities to continue to provide these evenings that are really, really, really incredibly helpful.
We certainly will. And thanks, David, as always, for doing this. And thanks to all of our participants for joining us. Thanks to the sponsors. Thanks to Marina, to Josh, and to Atul for their fantastic presentations. We've got lots of questions coming in. It's fantastic. And what we're going to do post-program, we're going to be sending you an email as a follow-up, and we will address succinctly the questions that have come in. If you have submitted a question, we won't frustrate you. We will address the questions. We appreciate it, and we will get back to you certainly very promptly with that, probably over the next week or so. So thank you. Stay tuned. We'll have some other programs on a periodic basis throughout the year, and I'm wishing everyone a great evening. Take good care.